Hey everybody, Peter Munich, Columbia University. Today I'm going to be talking about whether welfare programs might be able to slow the process of biological aging. I'll give you some nice urban background noises. I'm going to start off the talk by discussing the mechanisms through which welfare might slow aging. And then I'm going to briefly cover the results linking welfare programs to health using experimental studies. And finally, I'm going to be talking about how we might make welfare programs work in modern day society, or at least work a little bit better. So why are we even thinking about welfare programs for health? In the scientific literature, there are strong and consistent correlations. In fact, there's tens of thousands of studies on linking the socioeconomic determinants of health to some sort of health outcome using correlational models. And then I'm going to be talking about plausible mechanisms through which this might work. And, really we need this because if we know that there's a correlation between something, we also have to understand how it works. But that's still not enough to understand exactly how welfare programs might slow the process of biological aging. So let's dive into the biological pathways through which welfare programs might impact aging. You know all this from Biology 101. We are made of a code of DNA. It's a very, very simple factory in a cell with instructions on how to make proteins, and humans are little more than giant sacks of proteins filled with water. So the process of turning DNA into protein involves RNA, which reads the DNA, and then that code is translated into a protein. And you might think, well, that's pretty deterministic. But in fact, stress, environmental toxins, these kinds of things put markers on DNA that changes the way that it's read. So your exposures, it's very Lamarckian, your exposures throughout your day-to-day life actually alter the way that RNA reads DNA and therefore alter the ways the protein is made. This is a process called epigenetic changes. Over time, these markers start to create significant alterations in protein, and that is part of the process of biological aging. So how do we measure this? Well, you can measure the markers themselves, you can look at the proteins, or you can look at the exhaust from all these factories that are making the proteins. So we all know that we start off looking handsome and dapper and end up looking like Rudy Giuliani. How do we actually think about how this process works? Well, part of it is just, the clock is ticking on, and your factory is making proteins, and over time there's the markers accumulate and the proteins change. But the speed at which this happens is really determined by exposure to environmental stressors up at the top of the screen, major life events, and trauma and abuse. So, if you're abused as a child, that can amplify stressors, from your home, your work, your environment. And also having loved ones get sick and die can alter your stress response. So all these kinds of things change the perceived stress input. And whenever you feel a stress response, it activates a flight or flight mechanism. It can change behaviors like diet, smoking, drinking, exercise. And these changes in biochemical changes and exposures through diet and exercise create physiologic responses that produce epigenetic changes. So the speed at which you're aging is really determined by your environmental exposures. If you have a cush environment like the Buddha, when he first started off, you are going to have probably a slower process of biological aging. So how do we intervene on this process with welfare programs? Welfare programs mostly work at the home, neighborhood, office kind of level. Another thing that's worth mentioning here is that toxins can also impact epigenetic markers. So exposure to lead, PM2.5, these kinds of things are much more prevalent amongst low-income households and can also produce epigenetic changes. So that's all fine. Let's dive into the results from randomized controlled trials. So far we've covered the mechanisms through which this might happen. And I started off by talking about the correlation between poverty and health, or low socioeconomic status and health. Let's think about the policy implications of that. So this is a paper I did when I was just starting off my career, and I showed that when you use quality adjusted life years, a metric that combines morbidity and mortality, you find that poverty is a big social risk factor. It's bigger than obesity and smoking combined. So, if you could somehow wipe away poverty, you could have a huge impact on the burden of disease in the United States or in any country. The problem here is that welfare programs tend to intervene once we're outside of the uterus, but poverty really starts in utero. Most welfare programs are targeted towards single women in their 30s and 40s, or 20s, 30s, and 40s. So, how can we think about changing a lifetime of exposure to toxic stress with some sort of social policy? Well, when I started off my career, I really wanted to sort of build policy models. So do cost effectiveness analyses that will tell policymakers whether or not they're going to get a return on their investment. And to do that, I wanted to know for sure that particular welfare policies were working. So I first started off by looking at every old data set I could possibly find from many years ago that could be linked to death certificates. These death certificate experiments basically involve trying to get identifiers on the original participants in a study, linking them to their mortality status, are they dead or alive, and then looking at whether or not the experiment had any impact on mortality many decades later. The first set of experiments that I looked at were income experiments. So one was the negative income tax. That was a multi-state study in which people were either given money back if they were below a certain tax threshold, or taxed if they were above a certain tax threshold, and it was all on a nice curve. So that was a nice redistributive policy that was very tidy and very popular in the 1970s. Unfortunately, the data for these came on big magnetic tapes, and when we tried to feed them into machines, the machines simply crumbled up the tape. So, fail. Second was temporary assistance to needy families. This is also a multi-center study that was conducted in the 1990s in response to a concern really starting with Ronald Reagan that people on welfare became dependent on welfare. And he actually had a good point, because if you tried to get a job, you would immediately disqualify yourself for the welfare program. So you had to sort of either decide, am I going to try and make it in the working world, or am I going to stay on welfare? This had cross-aisle appeal, this notion that we need to do something about it. And temporary assistance for needy families was the response to that idea. So in this program, you can work and get welfare, but it's time limited. So after 5 years, you're cut off. A final program that I looked at was Project STAR, which is a multi-center randomized controlled trial that was conducted in Tennessee in 1985. And in this particular experiment, what they did was they took 11,400 students and assigned them to classes of about 18 kids or about 24 kids, and then followed them over their lifetimes. And what they found was that students assigned to smaller classroom sizes had much better scores on 4th grade, 8th grade, higher high school graduation rates, higher college attendance rates. So we should expect to see improvements in health because this group in the treatment group is more educated than the group in the control group. So what did we find with these two experiments with temporary assistance to needy families and Project STAR? Unfortunately, in both cases, we found that the treatment group, those with either more income or more education, were actually more likely to die than those in the control group. The reasons are very different between these two studies. In TANF, what was basically happening was there were lots of recipients that were on welfare because they found it very difficult to apply for disability. But they were too disabled to effectively participate in the workforce. So they had some sort of mental illness, they had a physical illness, they had social reasons for not participating in the workforce, like very large families, or they don't own a car. Those folks who could not work, once they were cut off their welfare benefits, their income assistance dropped down to zero. They became homeless, or they moved in with their family, extended family. And these are, again, single women with kids. So you can imagine that would put a huge stress on the person and expose them to an increased risk of mortality. That's probably what happened. In Project STAR, on the other hand, I think the culprit here is that we really only had follow-up through age 30. And being in a small class size, getting more attention from teachers and, having a higher rate of college attendance, all this kind of stuff makes you more social. And when you're more social as an adolescent, you're more likely to die. And so, in the first case, in TANF, we're seeing deaths associated with poverty. In the second study, we're seeing deaths associated with the kinds of things that sociable, more affluent adolescents die from. Swimming pool drownings, car crashes, that kind of stuff, alcohol abuse or drug overdose. We also saw it being in Tennessee. We saw a lot of shootings happening in the treatment group that weren't happening in the control group. So that might explain the difference there. But all in all, at this point, I'm having a lot of duds. So I'm finding that treatment with income either results in dissolved tapes or premature mortality, and treatment with more education results in premature mortality, at least through age 30. So I turned to two studies in the health literature, in the education literature, that had health outcome measures. These were the Abecedarian program and the Perry preschool program. Both of these were very small, randomized controlled trials, but very well conducted, super intensive. In Perry preschool program, the kids had an average IQ of about 80. The program starts at age 3 and intensively educates the kids. It also educates the parents on parenting skills, reading to the kids, those kinds of things. And the treatment group went from an average IQ of 80 to an average IQ of nearly 100, which is right on the mean. So this had a huge impact on their cognitive ability. And over their lifetimes, it had a huge impact on the kids. They were worth $1 million more than the treatment group per participant than the students in the control group. Why that big of a difference in such a low-income population? Well, the ones in the control group were much more likely to end up in the criminal justice system, whereas the ones in the treatment group were much more likely to end up in the workforce. So that added up to a lot of money pretty quickly. What we found in both these cases was, surprise, surprise, improvements in health. So now things are starting to look a little bit better. But I've run out of older studies that were conducted by other people, so I started to work with government agencies and subcontractors to see if we could start adding health outcomes to some of the ongoing welfare experiments. One of these was Paycheck Plus, which is a large randomized controlled trial that assigns participants to either receive regular benefits, which are tax credits for working adults, or 4 times those benefits. So they could either earn a tax credit of up to $500 if they worked, or up to $2,000 if they worked. And that experiment is now finished, and we're finding very mixed results. So we found in New York that things improved for the treated participants, and we found in Atlanta that things got worse. So much for all the great results. One of the most salient things about the Paycheck Plus program was that program uptake was very low. And so the participants in Atlanta that ended up doing worse actually didn't uptake the program. They didn't really respond by receiving tax credits and entering into the workforce. So, this raises the question of, what is it that we're really doing here with these welfare programs? And isn't it the case that, if we had just given the people the $500 and the $2,000, they would, they potentially would be better? My Goals for Healthy Aging is an experiment that we're looking at now that attempts to address this problem. It effectively helps people with their executive functioning skills by giving them the opportunity to set short-term, easy-to-achieve goals and to encourage them to achieve those goals. So one example might be, opening a bank account so that you can, start saving money. Or another one might be opening a bank account and having bill payments set up so that you don't forget to pay your bills and start collecting fines and fees. So these are very simple goals that are added on top of a huge work incentive. So about a $12,000 maximum per person incentive for those who do the executive function coaching and who go out and get a job. And we'll see what this shows. So far the program is running smoothly, and we have good allocation between treatment and control groups. We'll have the results from this program in about 4 years. So with Professor Cortan here at LSE in London, and we thought about some of these welfare experiment programs, and we kind of realized that a lot of these experiments that have been conducted have never really been scanned to see if they had health outcomes. So there's a lot of stuff that was just sort of in the gray literature, white papers, things like that, that were solid randomized controlled trials, but since they were conducted by government agencies, they were never published. So we combined the published papers and the white papers and looked through data sets, and we found 38 randomized controlled trials with health outcomes. And what we found was that the programs generally didn't do much for health. But that was partly because the programs generally didn't do much for welfare. If you look at the programs that were effective at improving people's outcomes, like their educational attainment or their income, those programs tended to produce benefits in health. And we didn't, we have all sorts of different measures of health, but they those programs that worked tended to improve health. So, what can we sort of like take away from all of this? I guess the spoiler is that, you know, experiments that work, that successfully improve income, housing, education, whatever, if they produce a sizable benefit, they'll probably also improve health. But most of these experiments found that it was really, really difficult to give welfare to people, even in experimental settings. So just putting cash in people's wallets in the context of conditional programs, means tested programs, is very difficult. So why is program uptake so low? Well, that question sort of takes us to the next segment of the talk, which is how do we make welfare programs work? Well, program uptake is low. We have to think about why that is. We also have to think about, the extent to which effective welfare programs are being translated into policy, and whether it's just sort of random studies that are being translated into policy. And my personal experience is spending my whole life, conducting research, social policy experiments, and writing cost effectiveness analyses, is that research gets translated So, sort of qualitatively, we have to think about this. So how do, what is the problem with all these programs? We have a real mechanism for translation of academic research into policy. We have four mechanisms at least, but it's random, and it doesn't really step back and address the core root of the problem, which I believe is not that we lack these kinds of social programs, but rather that the families that miss out on these welfare programs are generally those who are most in need. So, it's great that we have a whole bunch of social policies that could potentially improve health, but we should be more systematic about it, and we really need to think about those people who are not currently receiving welfare, who are most in need of welfare, and systemically address that. Now, thinking about this, we turn to the international literature. And China and Singapore are interesting examples because they basically worked on building institutions in the case of Singapore, or infrastructure in the case of China, to supercharge their economic growth and lift people out of poverty. So, when your nation is growing really quickly, it's very easy to lift people out of poverty, but only those people who can work. So this is not relevant for the US context. In these two Asian nations, family is really central. So if you have one member in your family that can work, the money gets redistributed to people who cannot. That's just not a model that works in places like the United States or the United Kingdom. So then we turn to a nation like India, which has used technology to overcome poor infrastructure and poor institutions. One piece of that is what's called a digital identity, which is basically just a way of verifying you are who you are and giving the government access to your data. That in India is done through something called India Stack, which connects multiple data sources like your work income, your bank account deposits, and things like that, so that the government can kind of transparently see everything that's coming and going out of your wallet. And that's good enough for them because they know who you are and they know where the money's coming and going, and the society is turning into a cashless society, so you can't really hide money. So the Indian government is pretty happy providing cash to people in need, and it's pretty confident that those people are actually in need without going through the process of cognitively demanding forms. In the case of the US, Medicaid or EITC, you have to file tax forms. Medicaid, you have to file proof of income forms and proof of employment forms and all this stuff to show that you actually qualify for the benefit. That's true of other welfare programs like temporary assistance for needy families. In India, you can just do it automatically. It's also true of other countries that have digital identity systems like Estonia, the Nordic countries who are actually using Estonia's system. So, this is a pretty exciting idea because if AI and digital identities can overcome weak institutions in countries like India, and they're also being used in Indonesia and the Philippines, etc., India Stack's being used there, then they can work for the US or UK because we're also nations with weak institutions, particularly institutions surrounding individual values about redistributing wealth. So, government agencies are weak. Families tend to not redistribute within families as much as they do in, say, Asia. So this India Stack idea, I think, holds a lot of promise. So in summary, welfare programs probably mostly work to slow down biological aging by reducing exposure to toxic stress and, to some extent, exposure to toxins as well. But conditional welfare programs like mean testing don't reach those who need them the most. So our focus should be on delivering welfare to those folks who need it the most, and technology offers a solution for countries like the US and the UK. Peter Munich, thank you for listening. Have a nice day.